Hey everybody, welcome to my YouTube channel. I'm Dr. Dinesh Raja and today we'll be looking at a case of cervical resorption. If you look closely, you can appreciate the discoloration of the cervical region. So as usual, I placed my rubber dam with some floss ligature and then I created my access using a small fine round diamond burr. I wanted the access to be very minimal and small as this is a cervical resorption case, which turned out to be not a very good idea. You will see why later on in the video. Okay, so now I'm just gonna check for the vitality of the tooth lah. So you can see there's some blood, which means that the tooth is still vital, but this case was actually spotted during a routine dental checkup lah. We took an OPG and we noticed that there's internal resorption. There was no signs or symptoms, so we had to interfere before it got any worse. So this is me just trying to poke my 10 size file into the canal, but it just wouldn't go through because there's just so much pulp tissue. Then I put in some full strength sodium hypochlorite just to cause necrosis of the pulp, which you can see happens quite instantaneously when you're using very strong. See, it's immediately becoming dissolved. Easier for us to go through the canal. So I'm just giving it some time for the sodium hypochlorite to work, and then I blow the sodium out of the canal and I'm just gonna observe. You can see that I'm currently viewing the teeth in like the highest mag that my microscope has, because I want to be very careful with this case because it is internal resorption. I don't want to cause more damage than I have to. So I'm gonna hit it with more sodium hypochlorite. That's going to be a very routine part of this case because we need very clean canals. Lots and lots and lots of sodium hypochlorite because we really need to get all the pulp out of the chamber. If not, this treatment would not be a success. So after I've done that, I move on to my coronal flarer. This is a rotary file that they provide in the OrthoMTA system. This is just to create a very big coronal flaring effect lah, but I use it sometimes to just remove the coronal pulp tissue, making it easier for me to clean lah. Okay, you can see I'm just aiming at the pulp straight. Continuing with my sodium hypochlorite. So most of the parts after this where there are sodium hypochlorite, I would fast forward it lah. Probably this is the last one that is in slow-mo. And then following sodium hypochlorite, I usually like to use my sonic agitation just to get into the spaces and nooks and crannies that I can't reach with my sodium hypochlorite needle. You can see the necrosis happening. Then I'm going to place a 10 file to get down to the canal. Now moving on to the 15. Sorry about the slight color change. Now that is my T1 OrthoMTA going to working length, and you can see the moment I hit working length, the pulp that is disintegrated is gonna just come out. So it's easier to flush out lah. See, all the vital pulps still in the canal has been disintegrated, and it's a bit more cleaner now. So sonic activation again, just to clean out everything, things that we can't see. And then now again to working length with my working file. This is T1, which is a 20 by 04 if I'm not mistaken. See, hypochlorite, always use hypochlorite, sonic activation again and again. That's what I do nowadays lah. Just hypochlorite and sonic activation. And then I realized that my access is quite small, so I started enlarging it with my round burr. You can see I'm making it slightly bigger, and there you can see more pulp tissue. So I've zoomed it in for you to have a closer look, and then I just used a probe to remove it, and slowly I realized, or I didn't realize, that my microscope has stopped recording. So after this, I just went in with my calcium hydroxide and gave it an intracanal medicament after I removed that pulp tissue. So you can see I'm removing the pulp tissue, and I will be successful at that point. I think at this point, right here, there, I got it out, and then my video got cut in a while. So I closed the whole access with diatem, and I took a X-ray to see my intracanal medicament, and you can see it is actually taken up a lot, except for the mesial where there's some deficiency lah. So this is my diatem. I've closed it, opening up my diatem, and that is teflon. I've really packed it well, just in case my temporary drops. I want my teflon to be waterproof lah. Nothing gets into my canals. So removing the teflon. Teflon is a much better choice than cotton pellet because it does not harbor bacteria. So it will keep your canal sterile lah. If you don't already know that, maybe it's a good advice for you to switch to a Teflon pack instead of using cotton pellets lah, if you have the luxury of doing that. Now you can see how well packed my calcium hydroxide is from my previous visit. I think this visit is after 2 weeks. Then I'm just gonna flush my calcium hydroxide out. You can see all the glooped up calcium hydroxide coming out. A lot of flushing and definitely sonic irrigation. That's gonna be a routine, so I'll just let the video run. You're gonna be seeing a lot of sodium hypochlorite activation with sonic irrigation, because that's how I do most of my endo cases lah, except for this part where I did some ultrasonic activation just to enhance the cleaning. So this is me at this part, just measuring the incisal length of the tooth so that I can actually compact my gutta percha beneath the root canal orifice lah. But I would suggest to compact it beyond the cervical 1/3 of the root, so that it's, it prevents discoloration of the tooth lah. So after irrigation, I'm going to insert a T3 file by Aurum Blue, which is a 35 by 04. So this is my final working file lah. After this, I would usually recapitulate with a K file size 10 to working length, just to make sure that my working length is correct before obturation. So you can see that lah. And wet trial fit of the GP. So you can see I'm using a T3 GP, which is a 35 by 4. So you should always try for apical tuck back lah. If that is fine, then you should move in with your paper points. So yeah, this is me drying the canal with paper points. So this is to show that it's really dry. Now the most important part, I'm using Cerasil here. Cerasil is very flowy, so it will take up any lateral canals or any missed canals or anything lah, and it's very biocompatible. So if it goes beyond the canal, it wouldn't be a problem. I'm using a paper point to absorb any excess, and then I'm placing my GP. Sorry, the paper point couldn't be seen. So after placing the GP, just shear it off twice. So the first shear will be to get better visibility, and the second shear will be as close to the root canal orifice as possible. And then definitely I'll be using a compactor to compact the GP beyond, if possible, the cervical third of the root. That means I'm in the root space. You can later appreciate this in the X-ray. So this is my first layer of MTA. I'm sorry I couldn't show you how I brought it into the into the canal, but I'm using a paper point, a F3 paper point, to just compact all the MTA to get a very finely compacted barrier lah. So after the paper point, I would usually use like a packer that I use for GP to really compress the MTA to get like a really good barrier. After a certain point, the MTA becomes hard. Okay, so I'm gonna add. So you can see I bring it in with an MTA carrier. It's basically like an amalgam carrier, but it's a bit more smaller lah. So I'm just gonna carry it into the canal. It's the same process. I'm gonna pack the MTA. See, packing. Make sure it's well compacted, especially in the mesial and the distal, because you saw right previously in the X-ray there was like a small leak, so we need to close that. After we've packed, when I'm happy with it, I think I'll be going in again with the paper point, because the paper point not only does it pack the MTA, it will also absorb some of the moisture, so it will give us a very good seal. Okay, so MTA takes 24 hours at least to set, but we usually don't have that kind of time, so we can either choose to put flowable composite or GIC lah. In this case I chose GIC, but before that we'll be taking an X-ray just to confirm how our MTA is looking like. So I'm very happy with the way the MTA is, so I'm gonna move on with GIC. You should use a slightly thicker mix of GIC to make it easier for you to adapt it into the canal. Okay, I'm gonna pack the GIC really well and then let it set for a few minutes, and then I'm gonna total etch my enamel and then wash it off, and then I'm gonna use a universal 3M Scotch Bond. Just scrub it in and then light cure. This is gonna take up any places where my GIC didn't fill, so it's gonna get a very good seal. After my flowable, I'm gonna cure it and then place some EverX Flow, which is a fiber reinforced composite, which is very widely used to replace dentin because of its properties. And then yeah, my composite. The excess was actually very small, so after I've placed my MTA, the GIC and the composites, there was not much place for a lot of composite lah. So just smoothen with stick resin, take off your rubber dam. I'm quite happy with the finish, but I'm just gonna polish it with my Eve. I think I went with red and white, but it only recorded my red. But yeah, this was after I finished polishing. So wait, let it focus. It has blended in well, so very less work for me to reduce the margins. Okay, moving on to the X-ray, you can see that the root canal has been compacted very well, and I've placed the MTA. You can see the MTA extending to the mesial and the distal side of the orifice, and the GIC has been packed well. The composite has been placed well with no voids, and I'm expecting the patient to have full recovery, and it should actually be asymptomatic lah. So we have seen how I would manage an internal resorption case. Hope you learned something, and if you have any doubts, please leave it in the comment section below. I would be more than happy to respond to all of them. So catch you in the next video. See you and bye bye.